My name is Dr. Christy Del Castillo-Heggie of the Fed is Best Foundation. I am a physician and scientist who studies breastfeeding complications and the effects of starvation on the newborn brain. This is a lecture on the physiology of fasting and its effects on the brain. Here I will discuss how adequate feeding, especially in the first days of life, can prevent brain injury from dehydration and low blood sugar. First, I will discuss what happens in the newborn during fasting and what caloric and fluid deprivation does to our living cells, including brain cells. Then I will review how many calories and how much fluid a newborn needs to feed all their living cells. I will then discuss what the latest scientific data says about the contents of colostrum in mature breast milk and what it means regarding newborn feeding. Then I will go over the signs of newborn underfeeding, dehydration, and low blood sugar. Finally, I will discuss the long-term effects of even transient episodes of starvation to the newborn brain. Let's begin. All healthy babies are born with all their living cells arranged in a way to optimize bodily function and brain development. This is a picture of a slice of the brain showing the many layers of cells arranged in a way that allows the delicate and complex progression of brain development to occur in order to form a fully functional adult brain. Every living cell needs oxygen, fluid, and calories every second of the day. Any interruption in fuel delivery from either severe dehydration or low blood glucose can cause massive cell death to the brain within minutes of onset. This is a picture of what 10 minutes of interrupted fuel delivery does to the brain. The light appearance on the left represents brain cells lost compared to the normal tissue on the right side. When a baby is fed, the primary fuel of the brain is glucose. As the body uses up the glucose from the last meal, extra stores of glucose stored in the liver are released. When the glucose from the liver runs out, living cells are sacrificed to produce glucose to feed the brain and other organs. Fasting occurs when a newborn receives few to no calories from a mother. If a newborn does not receive a full feeding, a baby will run out of glucose reserve from the liver, and the body will break down living cells from muscle to provide glucose for the brain. Ketones from fat can also be used as fuel during fasting. However, starvation is a state of fasting where the body has almost completely run out of glucose, brown fat, and protein reserve. When the newborn has completely run out of fuel, hypoglycemia or low blood sugar ensues. Hypoglycemia and starvation are life-threatening conditions that can cause permanent damage to the brain and vital organs. Hypoglycemia is one marker of critical starvation where the body is running on empty. Hypoglycemia can cause thousands of brain cells to die upon minutes of onset. This is the reason why newborns with identified risk factors for hypoglycemia are closely monitored for it and corrected immediately. Hypoglycemia to the brain is similar to the effects of suffocation or loss of oxygen delivery to the brain. The longer a baby experiences hypoglycemia, the more brain cells die. Unlike many organs experiencing cell death, brain cell death has severe and permanent negative consequences to brain development. Hypoglycemic brain injury results in the loss of the native architecture of the brain and can result in lifelong disability. This is a brain MRI of a newborn who experienced hypoglycemic brain injury. The light appearance reflects swelling, loss of brain tissue architecture, and cell death affecting half of the brain. The primary goal of feeding is to prevent critical starvation that leads to massive body and brain cell death. How many calories do newborns need to keep all their cells alive? And why do exclusively breastfed newborns lose weight? The daily caloric requirement of a newborn to keep all their cells alive is a minimum of 100 calories per kilo per day. This is also the number of calories required for them to not lose weight. Their daily fluid requirement is 100 mLs per kilo per day. For an average 3 kilogram or 6.5 pound baby, the daily caloric requirement is 300 calories at birth. Their fluid requirement is 300 mLs per day. Babies who are large, small, premature, or medically fragile may have a higher caloric requirement. According to a 2014 study of human milk, the caloric content of colostrum is 54 calories per deciliter, while mature milk contains 70 to 77 calories per deciliter. Unlike what is taught to every mother and health provider, colostrum in fact has fewer calories than mature milk. In addition, colostrum is present in much smaller volumes and is not present at all in some mothers. This is the published average daily colostrum production of a healthy vaginally delivering mother on the first 4 days of life. The average mother produces only 56 mLs on the first day, then 185 on the second, 383 on the third, and 580 mLs by the fourth day. This roughly correlates to a tenth, a third, and 2/3 of a newborn's caloric requirement for the first 3 days of life, then finally exceeding the full requirement on day 4. This is a graphical representation of the number of calories an average mother can provide a 3-kilogram newborn, the blue representing the number of calories colostrum provides, and the red representing the number of calories a newborn requires additionally to be fully fed. Only on the 4th day does an average mother's milk provide the full caloric requirement of a 3-kilogram newborn. Until that time, a newborn is fasting and relying on internal reserves to feed its vital organs. How does the newborn respond to fasting? The newborn loses weight. Weight loss of exclusively breastfed newborns has been widely taught as fluid loss through urination, despite the fact that they only produce 1 to 3 wet diapers their first 2 days of life. 1 to 2 wet diapers a day is an amount of urine output normally found during states of fluid deprivation. Newborns in fact lose weight because they are breaking down living cells in order to feed vital organs during the fasting state of exclusive colostrum-only feeding. This is a study of over 100,000 exclusively breastfed newborns. On the left are vaginally delivered newborns, and on the right are cesarean-delivered newborns. Cesarean-delivered newborns lose more weight because their mother's milk comes in later than in mothers who deliver vaginally. They lose more weight and do so more rapidly because they are fasting for even longer than their vaginally delivered counterparts. So why does an exclusively breastfed newborn lose weight? The same reason why we all lose weight. Exclusively breastfed newborns are losing weight because the caloric and fluid content of colostrum does not meet their full metabolic demand. They are losing weight because they are fasting. Why do we all believe that 10% weight loss is normal, especially when many newborns are crying inconsolably for milk before that weight loss threshold? Where does that idea come from? This idea comes from a 1984 study of 7 vaginally delivered exclusively breastfed newborns. 2 babies lost 10% and 1 baby developed failure to thrive, gaining minimal weight during the 4-week study. The study did not report on negative consequences of the weight loss and failed to report on basic markers of starvation like glucose levels and bilirubin. In addition, they failed to study long-term consequences of weight loss in the newborn brain, despite the fact that hypoglycemia, jaundice, and dehydration from weight loss were known causes of brain injury in newborns. 2 babies lost 10%. And that has established the standard of accepted weight loss for billions of babies. How can this be if our species was propagated by the practice of exclusive breastfeeding? If you look at the published data on native practices of breastfeeding countries all over the world, there is no historical evidence that we have ever exclusively breastfed from birth from a single mother. Before the WHO guidelines, 100% of native breastfeeding cultures independently evolved to supplement in the first days of life with prelacteal feeding, most commonly with the milk of wet nurses, animal milk, or sugar water. Before the widespread adoption of the WHO guidelines, the majority of breastfed babies in native breastfeeding countries were given prelacteal feeds before the onset of copious milk production by a mother. Why was prelacteal feeding common? The most common answer given by breastfeeding mothers is that their milk is not enough. In fact, a study of Nigerian nurses and doctors found that a majority gave prelacteal feeds to newborn babies. The nurses gave these feeds for so-called perceived milk insufficiency, while doctors gave them to prevent dehydration, hypoglycemia, and neonatal jaundice. The doctors discovered that by feeding a newborn baby supplemental milk before the presence of sufficient breast milk, they prevented the starvation-related complications of early exclusive breastfeeding. Now these complications are the most common causes of newborn hospitalization in the world. Mothers and health professionals are taught that the newborn stomach is tiny. However, where does this teaching come from? This is a widely distributed picture of what the newborn stomach size looks like. However, this estimation of the newborn stomach size comes from a 1988 study on the average daily colostrum production of 12 healthy, vaginally delivering mothers divided by 10 feeds a day. They did not actually measure the size of the newborn stomach. They assumed that the colostrum production of mothers should perfectly reflect the size of the newborn stomach. What is the actual size of the newborn stomach? This article published in May 2013 summarizing the findings of studies looking directly at the size of the newborn stomach through ultrasound and autopsy found that the actual size is 20 mL at birth. In addition, the stomach empties into the intestines during feeding, and newborn babies have been known to easily take 30 to 60 mL per feeding, depending on the size of the newborn on the first day of life. How much reserve does a newborn have for fasting? The length of time any individual newborn can tolerate fasting is unpredictable. It depends on the amount of time their mother is fasting during labor and delivery, how healthy the placenta is, and if there is any compromise to fuel delivery to the baby during labor, any stress during delivery and after delivery like abnormal heart rates and respiratory distress, which can deplete the glucose stores of a newborn, and lastly, the size of the baby determines the metabolic demand. Large babies and babies of diabetic mothers have increased requirements due to their size and insulin levels. Small and premature babies have increased requirements due to their lack of fuel reserve. How often does a healthy term exclusively breastfeeding baby run out of reserve and develop hypoglycemia? This is the first study of hypoglycemia in healthy term exclusively breastfed newborns, which was published in September 2015. They looked at newborns undergoing the baby-friendly breastfeeding protocol. The mother-baby dyad strictly followed the protocol, roomed in, the babies had good sucking reflex and latch, and an uneventful newborn course. They checked their glucose levels at 1, 6, 24, and 48 hours. 10% of all the newborns experienced episodes of hypoglycemia of less than 40 milligrams per deciliter, all the events occurring at 1 and 6 hours of life. They found that firstborn babies were at even higher risk, with 23% developing hypoglycemia within that time frame. What does hypoglycemia do to the brain? In a study of 94 newborns who had brain MRIs, they looked at the effects of developing hypoglycemia less than 46 milligrams per deciliter within the first 24 hours. They found that newborns who had hypoglycemia were 3.7-fold more likely to have brain injury visible on MRI. They followed these babies and evaluated their development at 12 months and found that the hypoglycemic babies had a 4.8-fold increased chance of lower scores in their motor, cognitive, and language development. This effect of hypoglycemia persists as shown by this study published in October 2015 of almost 1,400 newborns universally screened for hypoglycemia at 3 hours. They looked at the effect of transient hypoglycemia on a child's ability to pass 4th grade standardized tests in literacy and math. They tested 3 different cutoffs for hypoglycemia. For newborns found to be hypoglycemic less than 35 and 40, there were 50% reductions in their ability to pass the test in literacy and math. For newborns with hypoglycemia less than 45, they were 38% less likely to pass the test in literacy. What these studies tell us is what the basic science of hypoglycemic brain injury tells us. Hypoglycemia causes brain injury easily and rapidly and can reduce a child's cognitive potential irreversibly. The best way to protect the newborn brain is by preventing the hypoglycemia from happening in the first place. The latest studies on the incidence of hypoglycemia in exclusively breastfed newborns and the serious consequences of developing even transient hypoglycemia suggest that exclusively breastfed babies should be monitored for glucose similar to other high-risk babies. Glucose monitoring is the only objective measure of a baby's fuel reserve. Without that monitoring, only the baby knows when they have run out of fuel. There is absolutely no scientific evidence that supports that newborns can sustain days of fasting without experiencing critical starvation. As a result of this misperception, the most common cause of newborn hospitalizations in the world are from complications of underfeeding during early exclusive breastfeeding. The most common complications of exclusive breastfeeding before copious milk production are hypoglycemia, weight loss, dehydration, and jaundice, which together make up the syndrome of starvation. What are the signs of newborn hypoglycemia? For some babies, they have no obvious symptoms. Others experience fussiness, constant rooting, and nursing. Then they will develop inconsolable crying despite prolonged breastfeeding. Eventually, they develop exhaustion and sleepiness to conserve the remaining calories. Lastly, they will develop lethargy, inability to feed, unresponsiveness, seizures, and eventually coma. A severely hypoglycemic baby can develop irregular vital signs like low temperature, low heart rate, and compromised breathing. Newborn lethargy occurs when the brain is no longer supplied with enough calories to keep the brain awake. Typically, exclusively breastfed newborns who become lethargic in the hospital or at home are found to have hypoglycemia. The most recent article on lethargic newborns who developed hypoglycemia from insufficient breast milk intake suggests that by the time they are found lethargic, they have experienced hours to days of hypoglycemia. This study, published in September of 2015, described 11 previously healthy term exclusively breastfed babies who were found lethargic from hypoglycemia due to insufficient breast milk intake. They were found lethargic between the 2nd and 5th days of life. They lost anywhere from 0 to 16% of their birth weight, the majority losing less than 10%, which is a commonly accepted weight loss threshold. 5 out of the 6 brain MRIs obtained found injury affecting a third to almost the entire brain in differing patterns. The babies went on to have long-term neurological disabilities including epilepsy, diffuse body weakness, visual impairment, and feeding difficulties requiring speech therapy. How did we know how to supplement babies before the breastfeeding guidelines existed? This is how. This child is in distress and is clearly hungry. This is no longer an indication to supplement a baby unless they have developed clinical and laboratory markers consistent with starvation and excessive jaundice. This is what mothers are experiencing in real life. I was made to feel that breastfeeding was the only way to feed my child. My child suffered from lethargy, jaundice, and hypoglycemia while still in the hospital, and they discharged us anyway. We spent the next 2 weeks taking her to the pediatrician and hospital daily. Once we started formula, she began to thrive. I supplemented with the breast milk I pumped. Catherine Coiro. My son lost 11% of his weight in the hospital because the nurses refused to allow me to supplement, while simultaneously threatening to keep him and make me go home. Jennifer Jones. My child went through this trauma. He was born healthy and was fed continuously for the first 2 days. He was irritable and was always rooting in spite of being fed continuously. 24 hours later, he became unresponsive and was taken to the NICU, where they stated that his blood sugar had dropped to 0. The baby didn't get any milk from me at all. The hospital staff didn't even care to check if I was producing any milk. They blindly suggested to feed the baby continuously and didn't recommend formula. He had brain injury because of this. 1/3 of his brain got affected due to severe dehydration and hypoglycemia. Uma Sista. According to the current standard of care of exclusively breastfeeding mothers and newborns, mothers are not checked for presence or sufficiency of milk, nor are they assessed for risk factors associated with insufficient milk production. Exclusively breastfed babies are not monitored for hypoglycemia despite their fasting physiology. Inconsolable crying, which can be a sign of hypoglycemia, is not an indication for a glucose check or for supplementation. The standard is that newborns are rocked and soothed through the crying, but not supplemented. Supplementation is often only given once brain-threatening complications occur, after which a baby requires hospitalization that mothers are not told their child is at risk for. Mothers are not educated that insufficient breast milk is in fact common in the first days of life, occurring to 22% of all exclusively breastfeeding mothers and 44% of first-time mothers, and that supplementation can be required to protect a baby's life and brain. Mothers are not told about the possibility of starvation and the risk of brain injury until they have occurred to their babies. In addition, mothers are often ignored or denied formula when the babies are exhibiting signs of distress with inconsolable crying. If they insist on formula supplementation, they are often shamed and required to sign a form suggesting that they are negatively affecting their baby's health. Mothers are often sent home by 48 hours before they even have adequate milk to sustain a baby's life, and are told to not supplement with formula regardless of how much or how little milk they are producing. Babies whose mothers do not produce enough milk or produce it too late are often found at home too weak to feed or lethargic from hypoglycemia, jaundice, and dehydration. And the most recent article on lethargic hypoglycemic newborns suggests that by the time they are found lethargic, levels of brain injury that lead to lifelong disability have already occurred and cannot be reversed by phototherapy or supplementation. The standard of care is not acceptable. The Fed is Best Foundation is dedicated to the prevention of starvation-related complications and newborn brain injury caused by the exclusive breastfeeding guidelines. We believe that feeding and being fed are basic patient and human rights. A mother cannot be barred from feeding her inconsolable and hungry child, and a newborn baby has the right to be fed when they are starving and crying for milk. And unlike what many mothers are taught, an inconsolable, crying newborn who is losing weight from fasting is most likely crying out of hunger. Feeding is more important than breastfeeding because the brain will not wait for food. Any distressed newborn requires immediate evaluation and a glucose check. If immediate evaluation is unavailable, particularly to an exclusively breastfeeding mother who has been discharged before her milk has come in, supplementation should be offered immediately, as no benefit of exclusive breastfeeding justifies the risk of hypoglycemic brain injury. Once the baby is no longer in distress, the breastfeeding can be evaluated to assess technique, adequacy of supply, and need for supplementation. To learn more about the Fed is Best guidelines for protecting newborns from feeding complications, watch the upcoming lecture, Making Sure Your Newborn is Fed, soon to be released on fedisbest.org.